So with this new data emerging, I mean, and Noel, again, coming back to your expertise on bone, I mean, what's your thinking on bone protective agents now? Has it changed because of this trial, or can you just tell us that you've always known what you're doing and you've always been doing the right thing, and tell us what that is?
Well, what I hope it will do is highlight to the urological oncological community that this is an important issue. And actually, they should be using bone protection in a way they haven't been doing. It always interests me that clinicians, when there's good level 1 evidence for the use of something, they won't use it. And when there's no evidence at any level, they will use it. Now we know that this is a serious problem. And hopefully the message will get home.
Yeah. And do you think right from the start of starting ADT itself, right at the, in a patient beginning ADT, even for maybe non-metastatic disease, do you think we should be looking at their bone health even at that stage?
Definitely.
Yeah.
And there are very easy ways to do it.
Yeah.
You don't have to do bone densitometry. You can use simple FRAX scoring, which will give you an index of whether a patient is at high risk of osteopenia and osteoporosis. And in that way, you can just use a simple method, and usually a 4 milligram infusion of zoledronic acid is all you need, once, possibly twice a year, for bone protection.
Is that what you do, Nick, in your practice?
Similar. I mean, I think we know from the SEER data, where there's that very nice, very widely quoted graph with the numbers of pathological fractures picked up on the SIT. So these are real fractures. They're American insurance bills. And you've got a huge rate of fracture by 10 years out if you've had more than 8 doses of Zoladex or equivalent. And the only thing that doesn't appear to impact on the fracture rate is 1 to 4 doses of GnRH analog, which kind of runs with the prostatectomy only thing. The fracture rate is still significant in those as well, of course. So that's a separate issue about what you do with men not exposed to hormone therapy. But for men exposed to significant amounts of hormone therapy, the risk of fracture is substantial. So anybody with intermediate to high-risk prostate cancer that I'm putting on a couple of years of ADT, I'm measuring their bone density. I'm not treating all of them, but I'm measuring it. And those that that are osteopenic, I treat. Those that are not osteopenic, above, not below, I monitor, but I'll re-monitor. For the metastatics, I'm a bit more ad hoc about it because obviously but I'm doing bone densities on men with low volume metastatic disease periodically as well, because they will fall, and so if they fall, I will treat them. I'm not treating everybody. The FRAX score, the trouble is the FRAX score comes up as high scores on these men anyway, because of their age, they're on ADT and all the rest of it already. So one of the things we're going to look at with the Stampede data actually is we've just pulled out all the hospital episode statistics data on the patients in England, which is 80% of the total. And that will allow us to pull out data on orthopedic procedures that have happened for non-cancer reasons, because we suspect these are being underreported, because some bloke that we treated 5 years ago falls over, has a hip replacement, probably doesn't get reported into the trial database. Same applies to cardiovascular disease as well. Actually, we're concerned about that in multiple contexts, the abiraterone in particular. So
it's a good point that a lot of these patients, especially the longer term ADT, they may not be being picked up at all. We're not necessarily. It's not really a cancer situation. It's more of a osteoporosis.
And it's a statistical thing. A 75-year-old falling over and needing a hip replacement, you wouldn't necessarily think that was a cancer problem particularly if they're off treatment at that point. But if you've got an excess of them, then it is.
We're quite excited about this because we've got such a body of information now from the control arm of Stampede, thousands of patients treated with ADT, and then supplemented with super ADT, if I could use that phrase, abiraterone, and enzalutamide. So not only will we be able to do what Nick has said, which we are in the process of doing, but we can also do some sophisticated measurements on the CT scans which we have, which is sarcopenia, muscle mass, and so on, and the effect of treatment on that group, because falls are not recorded really. And again, now we're beginning to realize that somehow a fracture might not be osteopenia or osteoporosis on its own, but the combination of that with a fall may well be significant, which is muscle weakness essentially, which is an ADT-related thing.
Absolutely. So I very keenly recommend exercise to my patients because it obviously helps to stop them getting fat and it helps to keep their muscle mass up. And I think that's one of the messages we should be really putting out there, is exercise is good for you on multiple levels.
Yeah, it's a real opportunity with these men to sort of get them thinking about that as well.
Absolutely.